Good evening, everyone. I'll be talking about scleritis. I'll be presenting my case on scleritis, clinico etiological profile, and response to treatment. Scleritis is a painful, chronic, destructive, inflammatory disease of the sclera, can lead to vision-threatening complications, often presenting in 4 to 6 decades of life, can have an immune-mediated or an infective etiology, immune-mediated type being associated with RA most commonly, and is the first manifestation. Scleritis is the first manifestation in up to 59% patients with connective tissue disorders. It has been classified by Watson, as we all know, and shown on the screen. Topical corticosteroids and oral NSAIDs are the first line of treatment, with immunosuppressants and biologics being kicked in for refractory and unresponsive cases. Median time to resolution after starting treatment is longer for infectious scleritis as compared to the autoimmune type, and if not treated adequately can result in visual loss by spread to contiguous ocular structures. The aim of our paper was to describe the clinical etiological profile of patients with scleritis and their response to treatment regimens in a tertiary hospital. 11 patients diagnosed with scleritis with or without pre-existing systemic associations presenting to the hospital were included in our retrospective study, which was conducted from July 2022 to 23. Patient demographics, ocular findings, systemic associations, and treatment given, and also the outcome till the last follow-up was recorded. What we saw was the mean age at presentation was approximately 49 years with a female predilection, mostly unilateral, and the etiology was more likely immune mediated in all the patients. And the mean duration of disease till the time of follow-up was 4.5 years for systemic disease and 1.3 years for ocular disease. Pertinent to mention, 2 patients didn't have any systemic association and presented as scleritis as the first presenting symptom. The incidence of various subtypes was noted, and nodular anterior scleritis was found out to be most common, followed by diffuse anterior type, and we had 1 case each of necrotizing scleritis with inflammation, scleromalacia, and posterior scleritis. Systemic association was most common with connective tissue diseases, and 1/4 patients had association with vasculitis. Treatment regimen was started on a step-up approach, and immunosuppressants or biologics, which are the highest level, were actually required for all immune-mediated inflammations. Surgical intervention with scleral patch graft was required in 1 patient who presented with scleromalacia perforans. Infectious scleritis was treated with systemic corticosteroids, plus minus posterior subterranean and triamcinolone under antimicrobial cover. The various systemic agents used, systemic corticosteroids for all patients, antimetabolites like methotrexate for most of the patients, and then cyclophosphamide, and monoclonal antibodies were required for 2 patients. This image here shows the patient with scleromalacia perforans for which scleral patch grafting was done. Outcomes were generally good. Patients responded well with complete resolution in 10 patients, but there were recurrences of up to 8 episodes during the time of follow-ups in 6 patients. And 6 patients developed complications, cataract being most common, which led to deterioration in vision in 3 patients. There was improvement in vision in 4 patients, and maintained vision was seen in 4 patients. Visual acuity impairment at presentation was comparable to that at follow-up, but 1 patient who was not very compliant to treatment worsened to blindness. So our study basically showed features very similar to the existing data, but also has shown a positive response, like supportive evidence for immunomodulators that can help in the progressive relapses. But the limitation being a small sample size, which may not be a true indicator for disease pattern. Management of scleritis requires a multidisciplinary approach, and careful screening for systemic diseases is required in all cases of scleritis. Prompt initiation of treatment, use of newer agents may help in improving survival and delaying recurrence in refractory cases. Thank you.
Thank you. Hello. Thank you, Dr. Narula. Thank you, my colleagues, for being in this session. And thank you all the listeners. Thank you.
I thank all the chairpersons and the conveners and all the presenters. Everyone did fabulous, and I think they were take-home points for the presenters as well. And thank you, everyone.